Good evening, everyone. It gives me a great pleasure to welcome you all to today's scientific webinar, EHA 2026 Highlight. What's new in lymphoma, myeloma, and CLL? On behalf of organizing team, I extend a very warm welcome to all of our distinguished faculty, panelists, participants joining us this evening. We are delighted to have with us leading expert in the field of hematology, hemato-oncology, and BMT who will take us through the important update and emerging development from EHA 2026. To begin this evening, it is my great pleasure to welcome Dr. Sanjay Kamble sir. He is the Head Medical Affairs, Samarth Life Science. Sir, may I request you to kindly take over and introduce our Program Director, Dr. Abhay Bhabe sir, and take the proceeding forward. Over to you, sir.
Thank you, Khushi, and welcome everyone. On behalf of Samarth Life Sciences, it's my privilege to be in with the eminent group of experts who would be deliberating on various interesting topics for today. So before we start again, we would like to tell about Samartha that Samartha is a life sciences company who believes in manufacturing good quality products, and our mission is always to be a proudly heritage company that formulates innovative and differentiated products. And we have a group of 12 super specialty divisions, and Conquest division is one of those divisions which caters to the oncology part. And we have a robust manufacturing capabilities that manufactures hormones, injection tablets, and creams, as well as critical care products. And to do so, we have a R&D center at Bangalore and a factory at Baddi, wherein all the goods are manufactured. So Manthan is one of the initiative which has been undertaken by Samartha Life Sciences to be associated and be with the experts, wherein they will be guiding us on the latest updates that is in cancer. And today's very interesting topic about EHA was from devised by them, so that we take these scientific sessions to the other oncologists who may not have enough of time to attend these particular sessions that happened outside of the country. So for today, now it's my again privilege to invite Dr. Abhay Bhave sir, who is the program director for today's meeting. He's a senior consultant, hematology and BMT at Lilavati Hospital and Research Institute, Mumbai. And I welcome sir to deliver to give the welcome address, open the meeting, and then initiate the discussion for today. And following that, we would be having good, exciting sessions on it. So over to Dr. Bhave sir. Sir, please do the opening remarks.
Thank you, the entire team of Samarth, for bringing us all together for looking at these abstracts. They are abstracts which are not your run-of-the-mill abstracts. They are different abstracts. You'll see that they are about biology and therapeutics. So, and there'll be some breaking news also, what came up in EHA, that will also be presented. So I'm very thankful to my panelists for agreeing to present this. And I thank Dr. Sanjay Kamble, Dr. Khushi, Mr. Tiwari, Mr. Rajesh Sharma. All of them have been very keen on us getting together to be able to partake this knowledge, because I have not attended the EHA, and therefore I would love to hear what were the breaking news and what was the abstracts that were discussed over there. So I'll request Dr. Khushi Singh to again invite our first speaker so that we can start the proceedings. By the way, we'll take the questions at the end. So there is no separate case discussion as such. Whatever abstracts are discussed, if you have some questions, please write it down or put it into the chat or Q&A, and we'll take it up at the end. So let's just first present the abstracts. They're all different abstracts.
Thank you very much, sir, for setting the context for today's scientific discussion. We will now begin our first scientific sessions. Our first presentation will be focused on EHA Update 2026 and the area that continue to evolve rapidly with newer therapeutic and changing treatment approaches. It is my pleasure to invite Dr. Ramaswamy NV sir. He is a consultant hematologist, BMT physicians, Liz Hospital, Irakulam, to share the important update from EHA Update. Sir, over to you.
Has he joined? I can't see him anywhere.
Sir, just allow me one moment.
Yeah. Dr. Khushi, in case he has not joined or is delayed, we can go to our next speaker.
Yeah, sure. So I just had a word with him. He is joining in 1 minute.
Okay, okay. Okay,
Yeah.
thank you.
I think by the time he joins, you can take the next speaker.
Yeah, I'm open to that suggestion. No problem. Dr. Khushi, we can go to the next because he'll need to upload his slides and all that. No?
Yeah, that will take some time.
Yeah, we
Yeah,
can,
sure,
we can
sir.
go to the next speaker. Is the next speaker available?
Yeah, Dr. Ashish
yes,
is
sir.
here only, sir.
Yes.
We can take him.
Hi, Ashish.
Yeah, hi, Dr.
As-
Bhair.
Yes, Ashish, sir. So do you want me to share the screen for your slides?
Yeah, you can very well do that. That will be easier for me.
Okay, no problem, sir. I'm doing it. So, is this slide
Yes.
visible? Yeah.
Yeah, it is visible. Thank you very much.
Yeah.
So thank you for the invite, and the topic given to me is mainly the immunotherapies in myeloid disease and myelofibrosis. It's a mix of the two. Actually, it's not the immunotherapies in myeloid disease and myelofibrosis, what the slide deck is. The slide deck, of course, is courtesy Samarth Life Sciences. So the topic, actually, the abstract that I'm going to cover mainly involves the mainly the benign diseases as well as immune, say hemoglobinopathies. So it's a mix of both the conditions, malignant as well as non-malignant. Immunotherapy usually will not be in that. Okay, next slide. All right, so first presentation that was there at the EHA that I'm going to cover is for the ctDNA. Interesting study, which is mainly looking at the assessment of the ctDNA, and then predicting whether it can detect the development of lymphoma long before the lymphoma has happened. And this is the observation, which is mainly a single country-based analysis, looking at mainly lymphoma-associated mutations and trying to find out what is say predictability of the lymphoma development later. Next slide. So there is a very poor understanding on how exactly the evolution of the molecular event will take place. Both DLBCL as well as classical Hodgkin's, they will be arising from a germinal center B cells. In addition, I mean, DLBCL can be from the non-germinal center as well. These are also having recurrent genetic abnormalities in majority of the cases. So what we are trying to pick up is if there's a tumor-derived mutations that we can pick up way ahead of it. And that's what the study is about in the ctDNA assessment. Next slide. So this study was mainly based on the Dutch population. Mainly they had the luxury of having the pre-diagnostic plasma samples that was biofreezed years before these patients developed the lymphoma. So 46 individuals in the biobank samples. They later had a lymphoma and it was seen retrospectively. So 33 had DLBCL, 13 had classical Hodgkin's lymphoma. The matched tumor tissue and the white blood samples were available for 41 cases amongst these. So once they did the targeted sequencing for 115 gene and select super enhancer gene or 14 genes, they assessed both the single and the multinucleotide variants. There was a distinctive mutational pattern that they could identify through this aberrant somatic hypermutation, involving mainly the B cell regulation. So ctDNA was possible to be detected in 67% of the cases. Obviously, that was with the tumor-derived mutations identification there. 31 of these cases we could identify there. The interval between the sampling and the lymphoma diagnosis was 21 months, but some of these cases went on for years preceding the diagnosis of lymphoma. Next slide, please. So amongst the DLBCL, single nucleotide variants were detected in 39, but the multinucleotide variants were identified in 61%. In the Hodgkin's lymphoma, multinucleotide variants were detected in majority of these cases. In addition, it could identify the earliest detection that was around 106 months before the diagnosis of DLBCL and 55 months before the diagnosis of classical Hodgkin's lymphoma. So there is a strong correlation of ctDNA in addition with the serum thymus and activation regulated chemokine concentration, which is a recognized biomarker for the disease activity. Next slide. So the moment we come closer to the time of diagnosis, obviously the sensitivity for ctDNA to pick up these mutations are increasing. Tumor growth rate, there was no difference in picking up early versus late. It was similar. So the final conclusion of the study was if we do ctDNA and we are just concentrating on multinucleotide variants there, then possibly this is a very highly sensitive method and we can identify early molecular signatures that are associated with the lymphoma development. Interesting study, difficult to replicate in the real world population because obviously it requires a comparator arm as a pre-analytic one. But I think something that is very possible in the European region for sure because the biobanks are very active there. So yes, we'll look forward to more and more such data coming forward and then identifying if we can pick up a reliable signature from there. Next slide. Let's go to the next study. So next study is a benign disease. It is mainly related to pregnancy and sickle cell disease related vascular changes during the pregnancy that it is looking at. So there are biological changes that happen during pregnancy in patient with the SCD. And this year's EHA presentation was mainly concentrated on one presentation, which was mainly looking at this particular aspect. Next slide. So there is a pregnancy anyway in the sickle cell disease is a high risk and there is a higher morbidity, mortality. So obviously it is more of a concern the moment we deal with anybody with the SCD during the pregnancy itself. There is a typical pattern that we know in the sickle cell disease, endothelial injury, inflammation, hypercoagulability comes along. And these all things anyway are natural in the pregnancy. So these are quite hyperstimulated during the pregnancy itself. So the interaction between vascular and the inflammatory milieu during the pregnancy is poorly understood. And that's why there was, in this study particularly, the researchers, they tried to look at the proteotranscriptomic atlas of the pregnancy in the sickle cell disease and the important biomarkers. So there were serial bioplasma samples that were collected during each trimester and post-trimester limited case size, so only 6 cases, and they were compared alongside 8 non-pregnant. So very, very small study, maybe quite ambitious to start looking at this particular variable. And the analysis included the large-scale protein analysis platform, and the complement finding was validated separately. Next slide. So what was identified is there was 595 different abundant plasma proteins which are available in the early pregnancy, or 114 in the late pregnancy, which are mainly having some prediction value in terms of endothelial activation and the coagulation pathway, complement activity, or with the immune signaling. So there are dynamic interactions that are taking place. In addition, these are, say, the moment we say dynamic means they are changing as per the progression of the pregnancy. There were also there was a change in terms of overall cellular composition in the uncomplicated pregnancy, but endothelial hyperactivation and immune cell activation is much more common in the sickle cell disease. So very, very ambitious study, small population. I think it requires more assessment before we can put some thought into it. Next slide, please. Next slide. Yes. So now another study is mainly pertaining to only atherosclerotic changes, atherosclerotic cardiovascular changes to be particular in a beta thalassemia. Next slide. So with the increase in the survival of the thalassemia, now we are looking at the realistic challenge of having a heart condition that is coming in the thalassemia population. And we keep wondering whether thalassemia is increasing that risk or no. So this is a data that coming from Italy, which is looking at the clinical laboratory and the imaging data from 235 adults with the beta thalassemia, including both transfusion dependent and non-dependent. Around 15% patients of thalassemia developed atherosclerotic cardiovascular disease. Predominant sites were carotid, aortic, femoral arteries. Very few had myocardial infarction or ischemic bone lesions, ischemic brain lesions. Next slide. So what was identified is they are strongly associated with the atherosclerotic one, but the main take home for this particular study was these all complications are similar to what is found in the real world population. The thalassemia is not contributing over and above what we are seeing in general. So it's mainly the conventional cardiovascular risk factors are going to be the main decision makers in terms of development of it. So at least it gives some evidence of, say, reasonable importance that for the thalassemia, at least for these parameters, we can just ask them to be following as per the cardiology or the physician's guideline in terms of the lifestyle management. Thalassemia per se should not be the decision maker there. Next slide. So next slide is related to mitapivat in the pyruvate kinase deficiency. So this is a real world study. We already know about the mitapivat study in the pyruvate kinase deficiency, based on which it was approved further. Now this is a real world data that is coming from multicentric data coming from Italy. Next slide. So we all know it is a pyruvate kinase deficiency is where the mitapivat is first is going to have the major use. It is being explored in other conditions as well. So this was a retrospective study on 30 adults across the 9 Italian centers, both transfusion dependent, non-dependent. Response was seen in 67%. There was a very good response rate from a low hemoglobin to as much as 11 gram hemoglobin. Median increase was 2.2 gram. In the transfusion dependent group, on the other hand, 70% had a reduction in the group, let's say, transfusion need. So more or less similar to what we have seen with luspatercept in thalassemia or otherwise, but we need to remember this is a specific deficiency of the same pyruvate kinase, and this is a specific inhibitor to that. So it is mimicking what we have picked up in the original trial that led on to the approval of mitoprolol in this condition. Next slide. I think remaining parameters were more or less similar, so I'm not going to go into the details. Next slide, please. Another study, just I'll discuss in short. This is a pulmonary embolism study in the hematological malignancies. Relate whether there is higher mortality rate with that or no. Next slide. So the main thing is we remember that pulmonary embolism is carrying a high risk, but we don't have a data related to if the patients who are in a good control, if the pulmonary embolism develop in that, how much is a higher risk that they are exposed to. So in general, the age-adjusted mortality rate for the malignancy is coming down, but the pulmonary embolism developing in them is actually on the higher trend. Next slide, please. So what this study has found out is the mortality rate amongst the hematological malignancies with pulmonary embolism has increased across all dimensions, mainly in the males, Western regions, and particularly for the elderly population. They're also observed in the Black population as well as non-metropolitan. This is a Caucasian data predominantly from that area. So obviously, we need to explore whether it is the same in our population or no. But yes, there is a need for having a prophylaxis developed for this particular population. I think we are done with the studies from here. I think that's enough from my side. Over to you, Dr. Abhay.
Thank you very much, Ashish. It was beautifully described, and we'll take up these issues at the end so that we can ask other panelists whether they have. I have some thoughts which are penned down, but we'll do it at the end if you don't mind. So, Dr. Khushi, if Dr. Ramaswamy has joined, then let's go to Dr. Ramaswamy.
Yeah,
There.
sure, sir.
Welcome.
Yeah, I am available.
Okay.
Yeah. Sorry for the inconvenience. Okay. So, Kushi, you can proceed with the slide deck from your side, which I
Yeah.
share.
Yes, sir. So,
Yeah, but it's not a display. Yes. Go to the next slide. So I just took a few abstracts which are of clinical relevance. And the first one of that is normally we know that there are two molecules which are upfront FLT3 inhibitors taken together with the intensive 7+3 chemotherapy. And the one study which is currently being discussed is the one
sir, sorry to interrupt, but your voice is breaking in between.
Okay. Are they here?
Again, sir, it is not clear.
Okay. Just a minute.
Sure.
I think now you should be able to hear.
Yeah, yes, sir.
Are you
It's
able to
better.
hear?
Yes, sir. It's better.
Yeah, okay, right. So the first one is comparison of the alternative with the metastory in a patient with a newly diagnosed FLT3 mutated AML multi-center trial. In this, can you go to the next slide? The next slide, please.
Yes, sir. It has been shared.
Currently there are two FLT3 inhibitors.
So,
yeah, the one is the midastaurin based on the ratified trial. The second one is based on the quantum trial, quizartinib. Next slide, please. Next slide. In this multicenter trials, they have compared between the midastaurin and gilteritinib upfront. This one, it has been shown that primary endpoint of overall survival is not different between the gilteritinib as well as the midastaurin. Even the secondary endpoint. Next slide, please. Even the secondary endpoint of the CR rate after the induction is not different between the two molecules. Next slide. Next slide. Basically, even patients after the midastaurin-based induction treatment, when the patient relapsed, they have salvaged the gilteritinib-based therapy for the subsequent therapy. So there was no difference between the overall survival as a primary endpoint in this particular study between the gilteritinib midastaurin with the induction chemotherapy with the 7+3. Next slide. Safety profile shows that gilteritinib is having a slightly higher toxicity profile compared to the midastaurin. Next slide. The second topic is, we all know that menin inhibitor is playing a major role in a relapsed refractory setting of the NPM3 mutation or KNF2TA mutations. And one of the trial which is being phase 1B trial is a ceftinib, which is combined with the induction chemotherapy for a newly diagnosed patients with a NPM1 mutation or KM2TA mutations. And the trial is COMET 007 trial. Next slide, please. So here, the patients are being categorized as who was eligible for the induction therapy with the 7+3, along with based on the dose escalated with the ziftomenib is being added to that. And they have assessed the primary endpoint, dose-limiting toxicity, cumulated the complete response as well as adverse event in the primary endpoint, secondary endpoint, overall response, and the duration of the response. Next slide, please. The mean age was almost 60 in case of NPM1 mutation. KM2TA, it is around 43, and female is more or less equal. Race comparison is more or less equal. The co-mutations were FLT3 mutations were more or less equal. IDH1/2 mutations were slightly higher with the NPM1 mutations compared to the KM2TA mutation. Therapy-related AML was slightly higher with the KM2TA mutations. Next slide, please. So, yeah, in this, the safety and tolerability studies have shown that almost the differential syndrome was usually around 10 to 20%. When you start with the chemotherapy, the incidence is going down. Only 4% of the patient in the NPM1 mutation has developed, and 3 patients in a case of KNF2TA mutation. QTC prolongation was seen in a grade 3 in three cases, but of that, 1 is from the NPM1 mutation, 2 from the KNF2TA mutations. But none of all these things are salvageable, and there was no need to discontinuations. Next slide, please. The CR rate as well as the overall response rate was excellent. With in NPM1 mutation, it is going up to 96 to 98%, whereas in a KM2TA mutation, around 90%. Next slide. And CRC with the MRD negativity, it has been almost 80% for the NPM mutations. And even the cycle at which it is achieving the MRD negativity was within the 2 cycles, both KNF2TA as well as NPM mutation achieves MRD negativity. Next slide. Yeah. We all know that KM2TA mutation is having a bad prognosis. So here in a patient with a 7+3 with KM2TA mutations, after a median follow-up of 11 months, the median duration of the CR was almost 12 months. Almost 32 patients have underwent allogenic stem cell transplant as a consolidation, which is a standard of practice. 22 of the patients have continued with the maintenance post-transplant. 1 has dropped out of the study. The 10% have discontinued due to the relapse and refractory, and 7 were discontinued due to the adverse events. Next slide, please. In a case of NPM1 mutations, after a median follow-up of 17.6 months, the median duration of the CR was not reached. 80% of the duration was CR at 12 months. 10 NPM1 patients received hematopoietic stem cell transplantation, maybe because of the Q mutations. 31 NPM mutations entered maintenance treatment. 8 after the transplant. 22 without on-study in the transplant. 8 discontinued due to the relapse. 4 discontinued due to the adverse event. Next slide. So the overall survival, if you take it for the KM2TM mutations, it was not reached at 12 months, and the median age was around 43 years, and 60-day mortality was only 4%. So it was very well able to be combined menin inhibitor with the 7+3 induction who are eligible to receive the induction therapy. Next slide, please. So the conclusion in the COMET 1B007 was ziftomenib at 600 milligram once daily dosage with 7+3 is well tolerated, and the toxicity profile is not increased compared to the 7+3 regimen, and the robust clinical activity with the durable and the deep responses in the newly diagnosed NPM1 KMT2A mutations AML. So based on this trial 1B, there is an ongoing phase 3 trial having ziftomenib with a combination with the induction intensive chemotherapy in a newly diagnosed AML, which is going to be COMET 017. Next slide, please. Next slide. Yeah, another one was the multi-center phase 1B2 trial of azacitidine, venetoclax, ivosidenib, a triple combination in a IDH1 mutated acute myeloid leukemia. Next slide, please. We all know that established IDH1 mutated targeted therapy with HMA based on the VIALE studies, either
Hello, sir.
based on the slide, please.
So you're not audible. Hello.
Yeah. Now we are able to.
Sir, again it's breaking.
Hello.
Again it's breaking, sir. Again it's breaking.
Are you able to hear me?
Yeah. Not that
Okay.
much clear, sir.
Sir, I think you can continue because sometimes it may happen, but overall it was the network seems okay.
Okay, right. So I'm continuing. So we all know based on the VIALE studies in IDH1 mutations, azaven combination is working well, and based on the agile studies, azacitidine with ivosidenib is also doing excellent result. So based on these results with the basic knowledge, so the triple therapy as like FLT3 inhibitor with azaven being proposed. Next slide. Yeah, in this phase 1B studies where ivosidenib plus venetoclax dose escalation 400 or 800 along with or without azacitidine has been studied. And next slide, please. The primary objective was safety and tolerability because of 1B studies and the overall response rate. So it has been shown that the cumulative response, overall response is to the tune of 95%, with the CRC is 93%. And also MRD negativity is 91% MRD negativity with this triple combinations. Next slide, please. So the overall survival is 3 years overall survival is 79%, and the duration of the response is 83%, 3 years, and the cumulative incidence of relapse is only 9%. So based on this, the phase 3 randomized study of triple combination EVOLVE-1 for patients with a newly diagnosed IDH1 mutation AML is ongoing. Next slide, please. Next slide. Familiar by this time, the RT-AML studies, we all know that the duration of the venetoclax 7 days, 14 days, 21 days, 28 days, and also the dosage, what to be the titration of the dosage with or without azole group. So the rationale behind this study was VIALE established the role of azaven as a frontline for older unfit patient AML. in the paradigm studies suggest that it may have a benefit in certain younger fit population for the induction therapy. So then the question comes, the 28-day when is difficult to deliver in practice because of the myelosuppression, cytopenia, hospitalization, grade 3 infections, and other things. So the retrospective studies, various studies have shown that the tuning of the venetoclax days from 7 to 14 or 21 days suggests shorter when duration may preserve the efficacy and reduce the toxicity. So in the real world practice, when is frequently given for a shorter duration most of us. So asaven becomes the backbone of emerging triplet regimen for overlapping myelosuppression is a major challenge. So next slide, please. So in this RT-AML trial design, the patients who are more than 60 years randomized to 1:1 with either the arm is receiving the venetoclax 1 to 28 days, which is a typical standard established protocol, or because of the myelosuppression concerns and the equal efficacy, the study was a non-inferior of the AV14 to the AV20. Yeah, and then it has been compared. So in this study, bone marrow biopsy was done on day 21, and the patient who was receiving the 28 will be continued to receive. The primary endpoint was CR at the end of 2 cycles. Next slide, please. So it has been shown that based on the hypothesis established from the VIAL-A studies, the CR rate following the 14 days of win was AV14 is not inferior. That was the hypothesis compared to the 28 days. Assuming a CR rate of around 36% for AV28 based on the VIAL-A studies and 45% for AV14, hypothesizing faster count recovery leading to the higher CR rate, and that is what being concepted in this studies. So the planned enrollment of 160 patients equally distributed between the 2 arms, and the non-inferiority has to be established with the AV14 arm. Next slide, please. Even in the studies, it is the patients with other co-mutations are also being there in both the studies. So there was some imbalance between the mutation, some of the co-mutations. Next slide, please. So what the primary endpoint was? Next slide. The primary endpoint was AV14 complete remission rate was 43%, as against AV28 where it was 49.4%, almost the difference in CR rate of 6.4%. The 90% confidence interval was 6.1 to 19%. Next slide, please. So the clinical outcomes, the best response across the 2 cycles, if you see that CR and CRH rates were similar between the 2 arms. However, overall response rate, composite complete CR was numerically higher in AV28 as almost 6.4% compared to the AV14. Next slide, please. So, yeah, so the higher rates of CR occurred in AML with the NPM1 and IDH2 mutations treated with the AV28 compared to the AV14. Probably in a patient who is having a harboring NPM1 and IDH2 mutations, AV28 is better than that of the AV14. Similar rates of CR between the AV28 versus AV14 occurred in other genetic subgroup, including the TP53 mutation. Probably in these patients, maybe we can consider 14 days if the myelosuppression was the concern. Next slide. So the clinical outcomes, the survival of AV28 was slightly better than that of the AV14 in terms of the progression-free survival as well as the overall survival. So early mortality was not different between the two treatment arms, with majority of the patient in both arms are dying of disease or infectious complications. So reducing 14 days is not inferior compared to the AV28. If the concern was that it is a myelosuppression is the concern. Next slide. So factors impacting the survival was treatment was not associated with the overall survival in a univariable or a multivariable analysis. Independent predictors of overall survival included EHA performance status as well as the adverse risk mutations such as KRAS or TP53 mutations. Next slide. So the conclusion was AV14 did not demonstrate non-inferiority to AV28. CR benefit with the AV28 was driven by especially mutations like NPM1 and IDH2 mutations with similar responses in the other group. The two arms had genomic imbalances, making broad interpretation may be a difficult one. Toxic profile was similar across both arms, but the treatment interruption was more frequent in the AB28. 68% of the patient may have to interrupted the treatment in the AB28 compared to lesser than that of the AB.
Let's sorry to interrupt, but your voice
In
is not
the
coming.
AB14, this is very
Hello.
less. Our findings highlight the adjustment with prospective, without prospective data. Study is warranted. A novel AV triplet combination continue to be investigated rather than the uniform approach. Right? I'm handing to Dr. Abhay Babe.
Thank you so much, Dr. Ramaswamy. That was a phenomenal presentation. You really gave us phenomenal practical ideas that we can use in practice, especially with regards to acute myeloid leukemia, especially in terms of the molecular subtypes. I think that was really those 3, 4 topics that you discussed were really eye-opening. Thank you very much. Please stay back because we'll take the questions at the end if you don't mind.
Thank you.
Dr. Khushi, if you can go to the next.
Yes, sir. Thank you, Dr. Ramaswamy, sir, for the insightful presentations and highlighting the key development in acute leukemias and myeloid malignancy. So now moving forward with lymphoid malignancy, our next sessions will be focused on advances in non-Hodgkin lymphoma and DLBCL with several important development and treatment emerging from recent data. I am pleased to invite Dr. Arjun Philippe, sir. He is a consultant clinical hematologist, TMCH, Kolkata, to share the key highlight with us. Dr. Phillips, over to you.
Thank you, Dr. Kushi, and thank you, Dr. Avibavi, and other dignitaries and panelists for this opportunity. I'll be sharing my slide deck. Are the slides visible?
Yes, sir. Please go.
Yes, sir.
Okay. I'll be presenting on recent advances in the non-Hodgkin's and DLBL space. A couple of abstracts have already been presented, so I will not repeat those. So the first one is proteolysis targeting chimera, PROTAC. These are basically BTK degraders. So the utility of these in mantle cell lymphoma. So this was an abstract which was presented this time in EHA 26. So the background, mantle cell is characterized by an increased BTK signaling and activation of BCR signaling cascade. And we know that acquired BTK resistance is common in patients when on continuous therapy. While this resistance is more common in CLL, it may sometimes be seen in mantle. And the common mutations are the C481S, and sometimes you get L528W. Now, PROTACs are basically chimeric molecules which facilitate BTK degradation. So the aim of this study was to basically identify BTK PROTAC molecules which are capable of degrading BTK and suppressing the BCR signaling and ultimately leading to an anti-MCL activity. The secondary objectives was to look at strategies by which acquired BTK resistance can be overcome by these PROTAC molecules, and to try and validate the therapeutic efficacy and underlying mechanisms in both in vitro as well as in vivo mouse models of mantle cell. So the methodology, 24 BTK PROTAC molecules were studied, and these were basically screened for activity against various mantle cell lines. And the maximal inhibitory concentration assay, that is MIC50, and the BTK degradation efficacy was captured. Effects of various BTK PROTACs was studied via RNA sequencing and other molecular experiments. And basically, they looked at how these would affect the resistance genes as well as the BCR signaling cascade. And also, they looked at the ability of these molecules to reverse acquired BTK resistance in various cell lines as well as in the in vitro assays. So among the various molecules, the C23 PROTAC, that particular molecule was the one which showed the strongest ability to degrade BTK and to inhibit proliferation of various mantle cell lines. And it was seen that this C23 induced cell apoptosis as well as it suppressed cancer growth. And this was mainly by activating the ubiquitin proteasome pathway as well as inhibiting the BCR signaling cascade via NF-kappa beta as well as PI, PK, AKT, and TER signaling. Also, the degraded BTK mainly inhibited both the C481S mutation as well as the BTK L528W variant cells. We know this C481S is the most common one. And also in the MCL mouse models with these particular mutations, it was seen that there was a degradation of the resistance. So in conclusion, this C23 BTK PROTAC molecule was effective in inhibiting the MCL cells, even with the BTK variant resistance, and it is suggested as a potential therapy for BTK inhibitor resistant mantle cell. The other two presentations have also already been covered, so I will hand over the screen to Abhibhavi sir, because these have already been discussed in the previous presentation.
Thank you, Arjun. I think that was a very important abstract because, as you know, these BTK degraders are also making a huge wave in CLL.
Yes.
And therefore, I think since we're using so much BTKIs, I think this is a molecule, but we'll discuss it at the end. Thank you, Arjun, once again. And Dr. Khushi, can you please invite our next speaker?
Yeah, yes, sir. So our next speaker will be Dr. Chetan, sir. Sir is attending a consultant, Department of Medical Oncology, KIMS Hospital, Bangalore. Sir, over to you.
I'll be sharing my screen.
Yes, sir.
Good evening, everybody, and I thank Samarth Life Sciences for this opportunity. I'll be presenting on multiple myeloma breakthroughs from EHA 2026. So I'll be talking about three directions in the modern myeloma care. The first one being the initial therapy through daratumumab containing combinations. And second one will be better understanding of cellular therapy toxicity through CAR T cell biology. And the third one being the better disease monitoring through minimally invasive MRD approaches. So the first abstract is daratumumab in the frontline management of newly diagnosed multiple myeloma. This is an overview of systemic reviews and meta-analysis. Here the investigators performed an overview of systemic reviews and meta-analysis to determine whether daratumumab improves overall survival in newly diagnosed multiple myeloma. As we know, daratumumab is an anti-CD38 monoclonal antibody which is incorporated into several frontline regimes, including DVT, DARA-VTD, DARA-RD, DARA-VRD, and so on. The question is whether daratumumab merely delays progression or does it actually improve the overall survival. So what they have done is they have searched the 4 databases from inception through January 31st, 2026 for systemic reviews and systematic reviews and meta-analysis evaluating daratumumab based induction regimens and reporting OS estimates. And for quality assessment, they have used AMSTAR2. This assesses the methodological quality of systematic reviews, and to grade the for the certainty of evidence they've used GRADE. So when we look into the overall result, 8 systematic reviews and meta-analysis were included. Across the regimens, we can see that daratumumab containing therapy consistently has reduced mortality versus standard regimes. Although the certainty varied, the most robust data for OS benefit was from Cassiopeia trial, where they've used DARA-VTD with hazard ratio of 0.55 and DARA-RD from the Maya trial with a hazard ratio of 0.67. This was graded as high certainty. DARA-VMB also showed survival improvement in the Alcyon trial, but it was graded as moderate certainty. And for DARA-VRD, OS favored daratumumab arm, but it was imprecise. So the evidence for DARA VCD was limited because the confidence interval crossed more than 1, and the hazard ratio was 1.33, and there is no OS data for DARA KRD regime. So the overall OS evidence was rated moderate for DARA containing regimes, and primarily it was downgraded for imprecision. When we look into the table with the regimens DARA VTD and DARA RD have a better OS hazard ratio, and the quality of evidence is rated high. And for DARA VRD, the quality of evidence is moderate, and for DARA VMP, the quality of evidence is moderate, and for DARA VCD, the evidence is low, and for DARA KRD, it is very low. So if we look into the overall picture, adding daratumumab improves OS in newly diagnosed multiple myeloma. It is supported by moderate to high certainty evidence with mature benefit, particularly evident for DARA VTD, DARA RD, and DARA VRD, supporting routine use. However, the important caveat here is comparator intensity. The cross-trial comparisons are difficult because the control regimes differ. So DARA VRD versus VRD compares a quadruplet regimen with triplet, and DARA RD versus RD compares a triplet with doublet. So we cannot make direct conclusions that one regimen is intrinsically superior. Population treatment backbones, transplant strategies, follow-up, and comparator intensity differs in these trials. So daratumumab has become a fundamental component of frontline myeloma therapy, but the optimal combination and sequencing remain active questions. So we'll be moving on to the next abstract. It is CAR T cell detection and clonality assessment in immune effector associated enterocolitis following ciltacabtagene autoleucin. We all know that ciltacabtagene autoleucin is BMCA directed CAR T cell therapy, which is used in relapsed refractory multiple myeloma after at least one line of therapy. So one of the complication of this CAR T cell therapy is immune effector cell enterocolitis. So the pathophysiology of immune effector cell associated enterocolitis is poorly understood and may represent a clonal CAR T cell lymphoproliferative disorder. So they have done a retrospective review of patients with relapsed refractory multiple myeloma treated with standard of care cilta-cel at a single center from July 21, 2022 to October 31, 2025. So baseline characteristics, outcomes, and GI toxicities were reviewed. Digital droplet PCR was used to detect CAR transgene in GI tissue and peripheral blood. Conceptually, this asks, are CAR T cells physically present in the tissues? So T cell clonality, fragment analysis, and TCR-BC1 assessment were used to investigate whether the infiltrating T cell population was polyclonal or whether they represented expansion of a particular clone. And this was done using either IHC or flow cytometry of the T cell receptor fragment and TCR beta constant region 1. So in total, 201 patients were included, of whom 10% exhibited GI toxicity, and diarrhea accounted for most of the cases. CAR T cells were detected in 5 out of 20 GI biopsies. A clonal CAR T cell lymphoproliferative disorder affected predominantly the duodenum, and it was evidenced by TRBC1 restricted CD4 or CD8 positive T cells in the lamina propria. The cells were positive for CD3 and TCR alpha, while they were negative for CD103 and TCR delta. MUM1, CD138, and BCMA demonstrated absence of plasma cells in all samples. So TCR fragment analysis identified clonal TCR rearrangements in 3 out of 5 evaluable cases. The remaining 2 cases showed equivocal results with prominent but subthreshold peaks, likely reflecting low tumor burden. Though interestingly, symptoms resolved in 13 out of 15 patients without detectable CAR T cells, when compared to 1 out of 5 patients with detectable CAR T cells. Of the 4 remaining patients, 2 died and 2 had ongoing symptoms at the time of last follow-up. So GA toxicities was observed in at least 10% of patients with ciltacabtagene autoleucel therapy, and CAR T cell infiltration predominantly in the duodenum was detected in 25% of symptomatic patients, consistent with IEC-associated enterocolitis. TRBC1 restricted CAR T cell populations were detected in all cases, supporting the presence of a clonal CAR T cell lymphoproliferative disorder. But at the meeting, they were presented that additional translation studies from GI and peripheral blood CAR T cells, including whole genome sequencing and spectral flow cytometry and single gene RNA sequencing, are required for further validation. So the next abstract is whether can we do a minimally invasive MRD assessment in multiple myeloma using cell-free DNA, whole genome sequencing, and plasma proteomics. The background is MRD assessment in multiple myeloma informs the relapse risk, but it is typically based on bone marrow, and it is invasive procedure. So we therefore here they have compared minimally invasive MRD assays, that is bone marrow informed cell-free DNA whole genome sequencing and plasma proteomic MRD, that is called EZM. So there were 22 newly diagnosed multiple myeloma patients from 8 Canadian sites, and there were 71 longitudinal plasma samples, 22 at diagnosis and 49 during the follow-up. Each relevant sample was evaluated using cell-free whole genome sequencing and EZM, allowing direct comparison within the patients. When we look at the cell-free whole genome sequencing MRD approach, it analyzes specific mutation listed from the diagnostic bone marrow whole genome sequencing, and EZM approach. EZM used mass spectrometry to quantify residual M protein from the baseline. So the primary endpoint which they were looking at was progression-free survival. So when we look into the results, there were 22 multiple myeloma patients. Among that, 8 were male and 14 were female, and median age of diagnosis was 62 years, and 8 progressed at the time, median follow-up of 52.6 months. At 1 year of maintenance, with among 18 patients with available sample, cell-free whole genome sequence was MRD positive in 6 out of 18 patients. So this MRD positivity predicted inferior PFS with a hazard ratio of 20.12 with a significant p-value. This indicates a strong signal, although the confidence interval here is very wide because of small cohort. EZM was positive in 16 out of 18 patients because almost everyone was positive. Simple any detect positivity was not prognostic. So what they've done is they've done an exploratory clearance, the quantitative EZM threshold. So the exploratory clearance threshold of 0.93 classified 5 out of 18 patients as MRD positive and stratified PFS with a hazard ratio of 8.78 with significant p-value, improving agreement with the previous cell-free whole genome sequencing with a cap of 0.87. So using this threshold, we can agree with the data from cell-free whole genome sequencing, which showed MRD positivity in almost 6 out of 18 patients. So higher quantitative MRD burden was associated with inferior PFS. At 100 days post autologous stem cell transplant, EZM was uniformly MRD positive, that almost 100% of patients were MRD positive, while cell-free whole genome sequence was MRD positive in only 7 out of 16 patients. Applying an ECM clearance threshold of 2.13, 9 cleared versus 7 had residual disease. So this improved agreement with cell-free whole genome sequencing. Of 2 discordant cases, 1 cell-free whole genome positive and ECM cleared patient relapsed 38.6 months post collection, and 1 relapsed, 1 remained progression free at the last follow-up. So at post autologous stem cell transplant, both assays showed consistent but underpowered association with PFS. Across all post-treatment samples, continuous cell-free whole genome sequencing burden correlated with ECM residual M protein with a significant p-value. So what they conclude is bone marrow informed cell-free whole genome sequencing MRD strongly stratified PFS, whereas ECM required a clearance definition due to near universal early positivity. Concordant plasma burdens support complementary MRD information, and future work is to validate these findings in larger cohorts and quantify the incremental value of combined cell-free whole genome sequence and proteomic MRD for early relapse prediction. Thank you. I'll hand over the session to Dr. Abhay Bhavesar.
Just amazing, Chetan. I mean, it's what abstracts have been presented. Phenomenal abstracts. These are things that we normally don't look at. So, Dr. Kushi, you have one more?
Yeah, so one more session. Thank you, Dr. Chetan sir, for the comprehensive presentations and for highlighting the important breakthrough in multiple myeloma. So now proceeding with our next scientific program, it is on emerging advances in myeloid and lymphoid malignancies. So now for this we have Dr. Shruti Tushiwal ma'am. She is a consultant hematologist, BMT physicians, Sambhaji Nagar, Ahmedabad. Ma'am, over to you.
Yes. So I'll start sharing my slides.
Sure.
So are my slides visible?
Yes, ma'am.
Just one. So topic of today's discussion about the EHA guidelines. My topic is emerging advances in the emerging advances in the lymphoid malignancies. So we have few we learned about myeloma, we learned about lymphoma. Now few abstract on CLL. So this is the first abstract, real world outcome among Medicare beneficiaries treated with first line Bruton tyrosine kinase inhibitors for chronic lymphocytic leukemia. So as we know, covalent BTK monotherapies are standard of care for first line CLL in the US. However, there is lack of head-to-head BTKI trials in the first line setting, and previous real world studies have limited sample size and follow-up time. We don't have a head-to-head data. So what they did, they used a large US database to evaluate clinical outcomes among patients treated with BTKIs for the first line CLL. So methods, this retrospective cohort study utilized the de-identified Medicare fee for service database. Eligible patients included those with CLL or SLL diagnosis at the age more than 65 years who started first line BTKI monotherapy between 1st Jan 2020 to 6/36 2025 and more than 12 months enrollment pre first line. Outcomes included real world overall survival, time to next treatment or death, or time to treatment discontinuation or death from the first line therapy. Landmark trials and survival probabilities at 24 and 12 and 24 months were estimated using the Kaplan-Meier methods. Adjusted hazard ratios and 95% confidence interval were estimated among Cox proportional hazard models, adjusting for the race, sex, ethnicity, Charlson comorbidity index, and year of first line start. Subgroup analysis were performed by the different age groups like 65 to 74, 74 to 84, and more than 85. So there were total of 10,523 patients included in zanubrutinib, including 3,006 patients, Acala 4309 patient, and ibrutinib 3208 patient. Median age at first line was 77 years for Zanu and Acala and 76 for ibrutinib. Most patients were male, 58%, non-Hispanic white, 91%, and resided in the urban area, 78%. The median CCI score was 4 for Zanu and Acala and 3 for ibrutinib. At baseline, hypertension was 65% overall, and atrial fibrillation was 17% for Zanu and Acala and 12% for ibrutinib. Median follow-up was 16 months, range of 0 to 61 for Zanu, 21 months, range of 0 to 69 for Acala, and 35 months of range of 0 to 69 for ibrutinib. Median was not reached in all the groups. Median time to next treatment was not reached for zanubrutinib, 40 months for Acala and 39 months for ibrutinib. Median treatment discontinuation was not reached for Zanu, 24 months for Acala and 14 months for ibrutinib. Patients on Zanu had higher probability of survival, not advancing to the next line of therapy and not discontinuing treatment in 12 and 24 months than those receiving Acala and ibrutinib. For adjusting for baseline factors, and year of first line, patients on Zanu had statistically significant lower risk of death, advancing to next line or treatment discontinuation than those of ibrutinib or acalabrutinib. Similar results were observed across other age subgroups. So the conclusion are this is the largest cohort of patients more than 65 years with longest follow-up to date of and Zanu monotherapy was associated with better survival and treatment outcome compared to ibrutinib and acalabrutinib. So we go to the next abstract, the real world impact of atrial fibrillation on cardiovascular outcomes and healthcare resource utilization in patients with CLL. So background, while the association between AFib and CLL has been reported, the real world evidence on its clinical and economical impact is limited. The study evaluated impact of AFib on cardiovascular outcomes, stroke, bleeding, heart failure, and the healthcare utilization ratios in patients with CLL overall by age and by proton kinase inhibitor therapy. So the retrospective observational study used the US Symphony database to identify adults newly diagnosed with CLL from 2014 to 2024, 10 years database. Patients were followed for 1 year after CLL diagnosis to assess the incidence of AFib, subsequent cardiovascular outcomes, stroke, bleeding, heart failure, and the healthcare utilization ratios input inpatient, outpatient, other services were compared in CLL patient with or without afibrillation. Multivariate regression analysis assess association between AFib and the other outcomes. Subgroup analysis were conducted in elderly patient aged more than 65 years. Exploratory analysis compared first-line BTK use, ibrutinib, acalabrutinib, or zanubrutinib. So, a total of 362 newly diagnosed CLL patients, 13.1% patient had AFib in 1 year of CLL diagnosis. A significantly greater proportion of CLL patients with AFib had more than one inpatient visit within 1 year of CLL diagnosis than those with AFib, without AFib, 54 versus 23%, as well as higher likelihood to incur inpatient services. Significantly higher proportion of CLL patients with AFib had subsequent stroke, 14% compared to 8.9%, bleeding 27% compared to 19.1%, and heart failure 54.5 compared to 18.9, than those without AFib. Age more than 65, male, non-white, and AFib were associated with subsequent stroke, bleeding, and heart failure risk. Results were consistent in patients more than 65 years. In patient initiating first-line BTK, AFib rate within 1 year of treatment for first-line zanubrutinib versus acal versus ibrutinib was 11 versus 13 versus 16, and the p-value was significant. Compared to the first-line ibrutinib and acalabrutinib, a lower proportion of CLL patients with AFib treated with first-line zanubrutinib had subsequent stroke. 12% versus 9 versus 4.8%, and bleeding 27.4 to 21.5 versus 17.4, and heart failure 50.9 versus 45.6 versus 39.6%. So the results were CLL patients with AFib treated with first-line zanubrutinib has less inpatient services than first-line ibrutinib and acalabrutinib within 1 year of BTKI treatment. 46 for zanubrutinib, 51 for acalabrutinib, and 60 for ibrutinib. In multivariate regression, first-line acalabrutinib patients had 29% higher odds than first-line zanubrutinib patients. First-line ibrutinib patients had 69% higher odds than first-line zanubrutinib patients to incur inpatient services within 1 year of initiating BTKI therapy. So the conclusions were these findings highlight significant real-world cardiovascular and healthcare burden incurred by CLL patients with AFib. Exploratory analysis suggested first-line zanubrutinib may offer potentially favorable outcomes compared to other BTK in lessening AFib and related healthcare complications. Further studies with longer follow-up are warranted to confirm these findings. The third trial is real-world outcomes of lisocabtagene maraleucel liso-cel in patients with relapse or refractory CLL. The first results from CIBMTR. So liso-cel is an autologous CD19 directed CAR T cell product with established efficacy and safety across B cell malignancies. In Transcend CLL 004, liso-cel demonstrated a promising efficacy and manageable safety in patients with relapsed refractory CLL, those with previously exposed to Bruton tyrosine kinase inhibitors and BCL2 inhibitors. So here we report real-world effectiveness and safety of liso-cel in patients with relapsed refractory CLL. This observational study evaluated patients with relapsed refractory CLL who received commercial liso-cel and had one post-infusion assessment reported to CIBMTR. Effectiveness outcome were overall response, CR rate, duration of response, PFS and OS. Safety outcomes included adverse events of special interest, non-relapse mortality and death, and results were descriptive. Out of the 45 eligible patients, 64% were male, median age was 62 years. In patients with available data, all had ECOG performance status of 0 to 1, and 57% had more than one morbidity, most commonly more than 10% cardiac, more than 24% cardiac, and more than 16% pulmonary. Elevated LDH was observed in 35% and unmutated IGHV in almost 91%. Patient had median of 6 prior therapies and 71% received liso-cel as the fifth line or later therapy. Most patients, 84% were previously exposed to covalent BTK and BCL2 inhibitors, and nearly half, 47% had prior pirtobrutinib treatment. Bridging therapy was used in 48% of the patients. So what the analysis said, a median at the median 95% confidence interval, follow-up of 6 months, overall response was 84%, CR rate was 55%, 81% of the patient in CR with available data were MRD negative. Median duration of response, PFS and OS was not reached. Among responders, 6-month duration of response was 89% with median PFS of and OS of 77 and 87% respectively. Among patients, any grade of cytokine release syndrome or immune effector cell associated neurotoxicity syndrome. So any grade of CRS was 80%, with more than grade 3 or grade 4% was and any of the ICANS were almost 36%, and no grade 5 events occurred. Clinically significant infections were reported in 40% of the patient at 30 days after infusion, 18% had persistent grade 4 thrombocytopenia, neutropenia. Rates were low of HLH or mass, 7%, second primary malignancy, 2%, one case of basal cell carcinoma at 34-day post-infusion, tumor lysis syndrome, 7%, grade 3 for organ toxicity, 9%. Of the 5 deaths, two each were due to relapse or progression or infection, and one patient had multiple causes reported. 6-month non-relapse mortality was 5%. Among the 49% of the patient intended for outpatient infusion, 55% was hospitalized post-infusion with a median time to hospitalization of 5.5 days and stay of 5.5 days. So in routine clinical practice, liso-cel demonstrated response rate higher than in clinical trials with a consistent safety profile. These real-world data support liso-cel as an effective option for patients in relapsed refractory CLL with heavily pretreated or high-risk patient and has a potential for outpatient administration. Thank you. Back to you, sir.
Thank you very much. Phenomenal discussion and abstracts. Thank you so much. Dr. Khushi, do we have anything more to offer our audience?
Sir, we have discussions and Q&A.
Okay, great. So thank you, everyone. I mean, it was just phenomenal, the kind of abstracts that have been presented by all our speakers, and I'm deeply thankful to them for spending so much time and effort going through these slides and presenting it to us. Uh, what you may have noticed from this abstract selection, it's a mix of research and clinical. So we thought that we'd be able to present both aspects, because otherwise we are so used to listening only to outcomes in terms of use of a drug or a molecule, but how that comes into play and what are the new markers, all have to be also understood by us. So we'll start with Ashish's presentation. I think Ashish, his most important presentation was the ctDNA. Ashish, are you around? Is Ashish there or he has left us? So he presented on circulating DNA. What I gathered from his presentation, I've jotted some points, is that you can pick up about 14 genes in the peripheral blood of patients who have got floating ctDNA in lymphomas, be it non-Hodgkin's or Hodgkin's. And yes, they are under research criteria yet, but they have been picked up. ctDNA for lymphoma was picked up as early as 9 years in those patients that are Dutch study, 9 years before diagnosis for diffuse large B-cell lymphoma, and for about 5 years before diagnosis of Hodgkin's lymphoma. Therefore, uh, in our country, we don't have this kind of facility. So how do I view this DNA, the circulating DNA in our country? I think what we can look at it is from the point of view of, are we responding to treatment? So the depth of response beyond PET scan, because PET can also, beyond a particular limit, miss out on certain details. That's why patients relapse even after the PET scan has come negative. We can look at ctDNA as a method to look at MRD, the depth of response. That will be good, means deeper response. And third is, of course, we can look at the ctDNA from the point of view of genomic subtyping also. We can, use it to subtype even dark zone and for double hits, and in which the ctDNA is much more expressed. So it could be a kind of a surrogate marker for aggression of disease. That's how I view it in India. If Ashish is there, I would love him to.
Sir, I just checked with him. He is joining in 1 minute.
Okay, okay. So otherwise, my other panelists, what did you all think of ctDNA and these thoughts which I presented? Anything more that you would like to put in?
Sir, he
Dr.
had
Ashish
joined.
joined.
Yes, joined.
Yeah, Ashish.
Yeah, Ravi, sorry, I got
No problem. No, I
said
said that I loved your ctDNA presentation, and I said that for India's point of view, you can use it as a tool for responding to DNA. We can't collect it beforehand and come to know, because our insurance will not pay if we pick it up 9 years and 5 years beforehand. They say
yeah.
genetic disorder, so we have to be really careful. But we can use it as a means to look at response to therapy, depth of response to therapy as an MRD negativity. It might be a new standard other than PET CT scan, because I said people still relapse after PET CT scan is negative. And third is, it could also help us to tell about the aggression of the disease. For example, dark zone and double hit lymphomas may express more circulating ctDNA and will warn us that this is more likely to be an aggressive disease. So I thought I'll just get your thoughts and the panelists' thoughts.
Absolutely, I agree. I think what it is showing is mainly if you can predict, you can very well chase it, predict the relapses. Uh, you can very well design the therapies accordingly based on the persistence of it. So it has a huge scope. It's a fantastic study by, I think that's what I was saying, that European group has to be commended for mainly keeping the biobanks for years together, and they
Amazing.
still keep doing it. So I think this kind of a data is something that we are going to get from there. But yes, it has got a huge potential. Quite likely, we may see more use later. Right now, it is still under experimental use, so we'll have to see. But yes, I totally agree to all the points raised by you.
My only concern is that there has to be a cutoff, because at this rate, no one will be MRD negative, no one will be in remission. So somewhere
Yes,
to work out what is going to be the cutoff for that circulating DNA, because we don't know after how long, if 9 years have taken for them to become from CT positive to being a disease, then a circulating DNA post therapy, how long will it take for a relapse? We don't know. So
absolutely.
more data will be needed. Dr. Arun, you want to
Absolutely.
say something?
Yes, sir. I thought I would just share my the views. Yeah, so I think at least in DLBCL we don't have a pet adapted strategy even in advanced settings. So this I think is a good strategy, and I think on trial it is being done. So if we have something to adapt our some of the toxicities which we could avoid, we don't have to do 6 R-CHOPs in every patient. Maybe who is doing well. So my only submission is we will need baseline samples. So when you are like maybe we'll need to collect them and store them because most of these are NGS based. So we should have baseline samples collected, then only we can use it in the interim or end of treatment. That is one thing we should be watching out. And like what you said, so it's a beautiful strategy to complement what we are doing. PET, I think, is not an exact what we have had PET positive, PET like CMR, I would say dual score 3, and we are like wondering what to do with that patient at the end of treatment. This is a beautiful, I think, value addition to the data which is generated by the PET, especially in DLBCL. I think in Hodgkins, we have done a lot of justice. It is a lot of PET adapted strategies already in place. So I think in DLBCL, I think we can save a lot of toxicity. We can risk adapt it interim and then, escalate or de-escalate, and outcomes can really differ. I'm worried about the predictive part because it's like a biomarker when you throw up signals, circulating. Sometimes immune system takes care of some of these diseases, especially for Hodgkins. Like 5 year lead time, what we are saying may not, really be, I don't know how much of it we can act upon if you pick up these tumor DNAs 5 years or 10 years before. Is it actionable? That we really don't know. But I think in the interim and end of treatment, I think there's a lot to desire. And in India, the way NGS is coming up, our own, startups are coming up with a lot of these. I think it'll be not too far when we have these accessible to treatment decision making. So thank you, sir. Thank you, sir.
Great, Arun, but I'm just worried about the fact that there'll have to be some form of cutoff. If you're going to use ctDNA in Hodgkins instead of a PET adapted, or in non-Hodgkins to adapt to a ctDNA, we won't know what the cutoff is. So they'll have to work out a model where a certain limit, like in CML, you got 10% at 3 months, 1% at 6 months, and 0.1%. So you still have disease, but you're doing well. So I think we'll have to do something like that and find out how much it is. Dr. Phillips, you want to say something?
I think even in the Hodgkin space, with the newer immunotherapies and all, with PET response, sometimes the pseudo-progression is a big concern. And there is some data with Rachna Advani ma'am's group also, where they've used ctDNA as a tool to sort of monitor along with PET. So sometimes PET may be falsely positive because of nivolumab and other immunotherapies, and their ctDNA is more reassuring to tell us that we are on the right track in such cases.
Excellent. So if there's a positivity and you want to see whether there's false positive ctDNA, I think that's the fourth point. I'll write it down here as my kind of go-to for ctDNA. Thank you, Dr. Philip. That was beautiful. Anyone else? Otherwise, we go on to the next point. Dr. Khushi, do we stop at 9? What's the situation? Because we have quite a few things to discuss. Can we go a little bit beyond 9, Dr. Kamble?
Yes, sir, we can.
Just
Sure, sir.
Yeah.
We can discuss points that you have jotted down. Otherwise, there are certain questions in the chat boxes as well.
Yeah,
Yes,
we'll do
sir.
both, but just give us a little bit more time because there have been a lot of abstracts and a
Sure,
lot of
sure.
data
Yes,
shared.
sir.
Phenomenal. Okay, so just a quick point that I was very impressed with Ashish's abstract discussion about the mortality or the problems associated with pulmonary embolism and malignancies. So I think that was an eye-opener that while you get DVT in the lower limbs or upper limbs, but the mortality is more associated with pulmonary embolism. A point well taken, probably because of the aggression of the disease or the burden of the disease, which tends to happen, a burden of the DVT, which tends to happen with more aggressive disease. So I think the point is noted that if you get PE in a patient with CAT, cancer-associated thrombosis, the mortality rates are higher even if you are going to treat them. Dr. Ramaswamy, thank you for some brilliant abstracts that you brought out, especially where you compared Mido with gilteritinib. I think what you tried to show us is that really between primary and secondary outcomes, there's no difference between the two. Am I right? Is that what you said? And
Absolutely.
for my thought process, also gilteritinib is more expensive and it has got more infective rates. Yeah, am I okay with that? Correct with that?
Yeah, absolutely. Absolutely. So only the question comes is because some molecule which will come fast in the sitting comfortably, and then glutinib has come in the relapse settings. Unfortunately, it is not able to be proved for the upfront therapy because it's not a non-inferior studies or something like that. So, but my question is in the upfront therapy, whether the Quizartinib is going to take over the Midastore. That is where the question for me. Of course, if the future, if the cost is less and it is available, then the question comes that Quizartinib. Because based on the quantum studies, even though QTC study is prolonged and the study is extended up to 60 to 75, whereas in the Ratify is only up to 60 years, whereas quantum study goes up to 75, even though QTC studies and the myelotoxicity is little lesser. But what they have found out is that the disease-free survival as well as the response duration is better with the quizartinib rather than that of the midastaurin. Probably in the future, quizartinib will be comfortably sitting if it is available in India for the frontline therapy. Of course, the salvage if the gilteritinib is available, which will be for the salvage.
And can I ask you also to answer one of the questions from the audience? It's a question from, I don't know if I'm saying it right, but from Dr. Sachit. How frequently do we see midostaurin-induced marrow suppression? What are the strategies to overcome the same? And what are your views in adding midostaurin in consolidation to the same patient? So marrow suppression, overcome, and consolidation.
Okay. Myelosuppression is not that common as we think of. In general, it is very well tolerated up from day 8 to day 21. We never had an opportunity to interrupt unless the patient is going for a septic shock due to the primary, that 7+3, rather than due to the midastaurin 1. 2, most of the toxicity is a GI toxicity, which is a minimal and it's not necessary to be interrupted in most of the time. Third, and the consolidation therapy is also when the 7+3 is being tolerated, when the disease process is active, consolidation is not at all a problem in continuing with the IDOS or ASI, so should not be a problem. Question is coming maintenance, whether does it have a role that is not being proved. So that are the things. Definitely midastaurin lesser yes, it is, but not enough. Of course, midastaurin is also having a differentiation syndrome, but fortunately we are not seeing that much clinically. Most of the time when it happens, we come under the umbrella of the 7+3 post chemotherapy complications in terms of the infections and other things.
Great, thank you. The next paper abstract that you presented was on menin inhibitor in combination with 7+3, especially in patients with NPM1 and KMT2A. What I learned from you is that, of course, we all know that menin inhibitors are new molecules which have come into the market. And the menin inhibitors act by blocking the menin with its interaction with the MLL gene. And that's how it works. What you have shown me is that if you combine a menin inhibitor with, say, a 7+3, the depth of response is better. But from your discussion, I don't know whether it adds to the cytopenias.
Yeah. So it has been clearly shown there is no difference in the myelosuppression compared to the 7+3 alone. So it is not a prohibitive factors. Definitely it is being not well tolerated, but it's not adding to the toxicity profile, very clearly shown.
That's good to know. You also made a very important point that it seems to work better for NPM1 and the menin
which is quite common.
Yeah.
Because KMT2A biology-wise, it is a very nasty disease, which is bomb.
Disease,
But even in that cases, it is still showing a 80% response, 88%
but not
response
as a
is something.
maintenance. So not as a maintenance. You showed that
Not as a maintenance. But even in the induction, KMT2A response will be lesser. But we are getting the response of 80% with the menin inhibitors KMT2A. Of course, it has to be consolidated with the transplant, but still.
Right. You also spoke briefly on the paradigm, the using azaven in the young patients. I think I'm very keen and I'm using it in young patients, even if they are fit to take 7+3, because I'm seeing great responses. I don't know whether my panel agrees, but when I speak to them about 7+3 and azaven, and there's an opportunity to add a third agent after the NGS reports come through. But I'm becoming more and more keen to use azaven even for the younger patients. And I live to fight another day. I can always take them up for transplant if needed. I heard a beautiful statement made in the MHG concept of azaven. So I'm in favor. I don't know whether my panelists agree. Is anyone using azaven in younger patients who otherwise are fit for 7+3? I have done it after the discussion.
Yeah. The young and fit patients come into the terminology. Is it a less than 40, 40 to 60, biology of the person, how fit, comorbidities, all these things. It is not only that fragility index or the active infections. So it is not, age is also compared to this one. So when you say younger age, whether you mean less than 40 or 40 to 60, 40 to 60, yeah, probably with our experience. Now the question comes, of course, favorable risk. Once you know the because we are in the molecular era, you have to define the molecular, then you can decide whether to go for this one. So my recommendation, if you have a favorable risk, I will still consider to go for that, except for the NPM mutation. It is very clearly shown that beyond 65, adding 7+3 is not going to be helpful. Younger patients, 7+3 is doing very well for NPM mutation. Of course, the study in the space 1B of this, what I presented. So additional menin inhibitors will add to the point of the benefit. Now, for the intermediate risk, whether the question is 40, 40 to 60, above 60, probably above 60, everybody is comfortable. 40 to 60 depends upon the presence of infections at the time, where obviously he is fit, fragile, and everything like that. Less than 40, definitely I'll be considered, because when I say the word of intensive chemotherapy, I'm considering for the curative options. When I am seeing that azaven, unless you are consolidating with the transplantation is the one thing. When you're not thinking of the transplantations, probably you can think about whichever the way you want to control of the disease, duration of the relapse rate, or survival like that. Yeah, when you word the concept of the cure is considered and the transplant is being consolidated, then you can choose whichever you would like to have it. That is what it is. Varun wanted to say and think. Arun?
Yeah, Arun?
Yeah. Yes, sir. So I just said, I just want to add that azaven is a very safe way to get to remissions. So you will get to remission. So you do some induction. But what probably we lack now, even today, is what is the best consolidation strategy when you do an azaven? How many HiDAC and before transplant? And we don't have data, sir, to counsel our patients when you discuss it across. Like what would be the 3-year or 5-year OS data? So I think like when you haven't lay down data, like when you do 7+3, you do HiDAC, you do take a patient for transplant, you have a predictive algorithm in place. If for Indian population, I completely agree with the entire group here. Anthracycline is most toxic. Most of our patients would die during induction. 30% mortality MDR bugs. So what I have done, and it's part of my trial also, like I'm doing flag-ven instead of azaven. And when I'm doing flag-ven, I've been able to, reduce the induction mortality to less than 10%, that is single digits. And I've been able to take even elderly, like 60-year-old to transplants. So it again, I told you, so even in that, what is the best consolidation and what would be, these are all like hypothetical. So that's what I just want to say. Azaven is easy on the patient and the doctor because we don't lose out so many during induction. But how best to consolidate that patient and cure most of them? I think if you have a young fit patient, we don't have enough data to support that algorithm. That's what I just want to share with the the experts here, sir, my views.
What was the duration of the venetoclax?
Sir, in flag-ven we do 10 to 14 days. That is what we do, not more than that. Because when you do flag, it is an intense regimen. And they can't, generally, the myelosuppression is very bad when you do beyond 14 days. So I do 14 days of flag.
No, 14 days is so a lot.
Azaven, it's highly varied. First cycle, I end up purely doing 10 to even 14 days. I do day 14 marrow and then take a call to, continue it or, stop it at that point. For a young fit patient, when I'm latching on to azaven, I've been doing like 14 to 21 days. Sir. But for a patient where cure is not the intent, it is just adding some PFS benefit, I am more safer. I do 7 to 10 days. Don't go beyond
What was the RRC dose? What was the RRC dose in flag?
No, standard, so 2 gram per meter square, 3 days, the standard protocol, nothing sort of that. No deviation from the standard flag protocol. Sir.
Okay, the next abstract which I got from Dr. Ramaswamy, which also I liked, was the optic AML, the amount of ven that you will use. And I'm also happy to see that on the basis of a molecular subtype, we can decide how much ven to give. And what we learned from your abstract was that if it's a NPM1 or a IDH2, 28 days of ven is going to be better. So at least now you're given
21 days, 21 days and above is better.
So you're given us a pointer as to where you can use lesser ven and where because it is expensive, where you can use lesser ven and more ven. So that's great. We'll come to Dr. Philip Sarijan's PROTAC, BTK inhibitor, a BTK degrader. I think I just heard Nitin speak yesterday on CLL, relapse refractory CLL, and he's about the BTK inhibitors, BTK degraders. And the beauty is that you can degrade it so that the BTKI can also become useful again. So it reduces the inhibition. And I'm happy to know that it has been tried also in MCL. So it's going to be another drug added to the armamentarium of management of patients with BTK. The question I wanted to know or to ask was, if you use a BTK degrader, can you go back to using the BTKI inhibitor? Will you have to use both? Or does the BTK degrader overcome the inhibition and therefore you can get off one drug, or you have to continue both? Arjun, any idea if you have got data about that? Do they need to be continued together continuously, or it is only till you document that the BTK inhibitor, that mutation is gone?
I'm not aware, so I'll have to look up and get back to you on that.
That looks like a nice one, but I don't know whether if we are going to use two drugs simultaneously, is that going to add to cost and toxicity? But that was nice that we can still use a BTK. Everyone wants to use tablets, not injections.
So there is data on BTK degrader with venetoclax. That I remember.
With
that I've read. Yes, sir. Yes, sir.
So I think venetoclax has become a big game changer. It's used in across malignancies and it's making a huge difference to management. Certainly, my ability to treat AMLs, especially the older ones, has improved vastly thanks to the advent of venetoclax. There's no doubt about that. We'll come to Chetan's presentation. Thank you, Chetan. Beautiful presentation. You spoke about Prospero, 4 databases looking at daratumumab. And it was always said that addition of daratumumab would be beneficial. But you have now shown with certain amount of certainty that daratumumab is beneficial, including for not only PFS, but also OS. And you clearly mentioned it in the Maya study of DRD. You showed it in the DVTD, that was the Cassiopeia. And you also showed it to some extent in the DVMP, is alcyclone. I'll never be able to say it. So in these 4 trials, you have shown that overall survival of DARA addition was better. And I feel one of the criticism in your slide was that, comparators, but when you have got a new molecule, you will have to compare a 4 to a 3. So I think that is a fair comparison. You also showed that the DVRD is low certainty, but it has got some benefits. And the West has gone to DVRD as first-line treatment, or the opening batsman, irrespective of what the risk status is, irrespective of whether they're transplant eligible or ineligible. They'll go for DVRD. So I thought that addition of D to a very potent VRD is adding on PFS and to some extent probably also overall survival. So that was good. Then you also spoke about the CAR-T in relapsed refractory multiple myeloma. Well, actually, the incidence of enterocolitis means as an infection, infective diarrhea as such is higher. What you try to point out is whether that diarrhea was initiated by the presence of the CAR-T in the intestinal lumen. I thought it was a phenomenal study. Thankfully, with cilta-cel, the incidence is lower. I think with cilta-cel, it had what? It was 2.2%. With ida-cel, it is 1.2%, if I'm not mistaken. So it's much lower. Therefore, those who have got higher incidence, who had an ICANS during their CAR-T therapy, are the ones who are more likely to get this enterocolitis from what I have read. And those who had a higher absolute lymphocyte count at that point of time are likely to get the enterocolitis because of CAR-T. And this enterocolitis of CAR-T tends to occur 90 days after CAR-T. Usually it doesn't occur immediately, and that's a way to differentiate it from infective episodes. So nice 3 points that you gave us. So thank you very much for that. Can we go on to the next one, which is Dr. Shruti's? Dr. Shruti spoke on, she introduced us to CLL abstracts, and she showed us in the real world phenomenal number of patients looking at the first generation BTKIs, ibrutinib, acalabrutinib, zanubrutinib. And from her abstract, it was very clear that in terms of overall survival and progression-free survival, as also possibly atrial fibrillation rates and heart failure rates, zanubrutinib wins. Zanubrutinib is available in our country, a little expensive, but doable. From what I had read about zanubrutinib, we have to be just concerned about the higher incidence of infection, which occurs especially in pneumonias. So it's no different from the other molecules. Today, we are hardly using ibrutinib because of the cardiac issues, atrial fibrillation, which, by the way, in her beautiful description and discussion on the abstracts, ibrutinib has a higher incidence of atrial fibrillation than the other two. Acala and zanubrutinib are numerically different, but I don't think they are statistically different. So they are numerically different, but not statistically different. So that was good. From what I understood, it has only been looked at 1 year. We are using BTKI for years. Therefore, we need data beyond 1 year. So in 1 year, there might be an underlying cardiac condition which might just get aggravated during treatment, and you might attribute it to the drug. So we'll have to just see whether the patient did not have any cardiac issues prior to starting the drug. And all this, there's a higher incidence of atrial fibrillation, higher incidence of stroke, and higher incidence of heart failure, almost 54% when you're using ibrutinib or acalabrutinib, and it's a little less with acalabrutinib. And this mainly occurs beyond 65 years of age, not lesser. So thank you. I learned a lot from this abstract. And then you came to the CAR-T. In CAR-T, you spoke about use of CAR-T in relapse refractory. Again, I heard Nitin speak on it yesterday. He has great responses. And what is the beauty of CAR-T is it is independent of the risk factors. It doesn't make a difference whether you're TP53 mutated or whether you've got complex cytogenetics or IGHV mutation. It works any which way. So it's independent of risk factors. Therefore, I think CLL CAR-T might work, and they are very good responses and they're durable responses. And they might work much earlier than what we feel. We have fortunately 3 lines of treatment available. A CAR-T being expensive, we are keeping it towards the end, but scientifically, maybe CAR-T will be a good option unless the combination of VO, when obinutuzumab, or combination of a BTKI with BCL2, when with Acala, let us say, or when with Zanu, the data of when with Zanu is phenomenal. So it's going to give us as much and as good as CAR-T will give. So we'll have to look at that also, whether the oral will match CAR-T over a period of time, purely from the point of view of cost, which is much more staggered rather than one shot. And remember, CAR-T in CLL, you need a less bulky disease. A bulky disease may have its issues. So less bulky, so something to debulk and then to use CAR-T if you're going to use it. Otherwise, combinations will also be very helpful. I think these are my notes. Panelists, you want any other thoughts to come out? I think if Dr. Ramaswamy is still there, Dr. Phillips has a question. In FLT3 positive AML, Dr. Ramaswamy, if you open the chat box, the question is there posed by Dr. Phillips. I'll read it out for the sake of the audience. In FLT3 positive AML, post-allogeneic transplantation, would the experts give post-transplant maintenance? And if so, would you give midostaurin or something else?
Okay. Current study is available only for the soravin-based studies, post-transplant maintenance. But if you see the glitinitive trial, what they have done is, if the patient achieves MRD negativity pre-transplant, the efficacy of the glitinitive post-transplant maintenance is not that make the difference. So basically what they are saying is, if you achieve MRD negativity, the pre-transplant, the role of the post-transplant maintenance is doubtful, but still people is still having the usage of the FLT3 inhibitor post-transplant. So available therapies are 2 things. One is a alternative post-transplant maintenance, as well as the soravin based on the soravin trial, sorafenib. Midostaurin is not being routinely used at this point of time because of the data is not available.
Not available, yeah. And in NPM1 IDH1 mutated elderly AML, who's transplant ineligible, frail, would you use aza-ivo or aza-ven first and then go on to consolidation? I think this was what Arun had also brought up. So let me put it in another way. If you got IDH1, will you use aza-ven initially, or you'll use all 3? Or you'll use 2 of them, aza with ivo?
So if you have both the mutation or 1 mutations, if you have IDH1 mutations, definitely based on the agile study, I will go for the ASA plus ivosidenib. Because of 1, those patients who have responded to the ASA-Ivo, when the disease is relapsing, they may respond to the ASA-Ven. but the vice versa is not seen. When the patient was put on azaven, then the response may not be that significant. Second
Okay.
thing is myelosuppression is not there. Third
Yes.
thing is neutrophils are coming up within 8 days of starting the therapy because of the differentiation syndrome is known in these cases, and especially in the presence of ASA, differentiation problem complications are less. So I will go with the, if you take IDH1 mutations, I will go for a, if the cost is not prohibitive, I will go with a, if the cost is prohibitive, what I am doing is azaven is the therapy for IDH1 mutation. NPM1 mutations, at this point of time, it is doing excellently well with the azaven, especially with the 3 weeks course of the venetoclax. I will go with that. Now, question is, will you add venetoclax to that patients? Sorry, I mean, menin inhibitors to that? Probably in the future, we'll say at this point of time, NPM1 is responding beautifully with azaven. Now, the question comes if somebody is asking both the mutations are there, which one you will give importance to that? Because NPM1 is a driver mutations. I have to consider about the NPM1 mutation rather than the IDH1 mutations. So I will consider the NPM mutations a priority to treat for that. In that case, I will go for the azaven, which has been proved time tested for the response treatment. Whether to add menin inhibitor and then we have to add this one, I may not consider at that point, this point of time.
Okay, I think we have really overshot time, and before we are asked to leave, I think it's best we hand it back to Dr. Kamle and Dr. Khushi. I'll thank my panelists for a phenomenal discussion. Sorry, Ramaswamy, you want to say something?
Yeah, because Varun, if he's asking something he has in his mind, can I expect what is his thought process?
So I have an elderly patient right now with me who is NPM1 IDH mutated. So I've started. I mean, she's affording everything. So I have initially given her. I mean, I wasn't I wasn't aware of that. You know, using IVO upfront will. Using when upfront will later on lead to a resistance in IVO. I wasn't aware of that, and
No,
now
but
she has
I'm saying
completed
that
3 cycles. Yeah, now she's
yeah, but
completed 3
since
cycles.
both the mutations are there, I will give importance to the NPM because it's a driver mutations, and the
Yes.
response to the azaven is better with both NPM1 as well as IDH1
As well as
mutations.
IVO, yeah.
I will consider go with the azaven rather than going for the ivosidenib.
So
If your
now
question
the
of
thing is,
IDH1 alone comes, that is a question. Varun, I would like to add something you have in your mind.
If Abhay sir would permit.
Varun always has something in his mind.
No, that will be a logical. That is why I'm pulling in.
No, thank you, sir. Thank
Yeah,
you.
Varun.
I. So my comment is, like, when you have a hypothetical IDH1 and an NPM1 mutation who's transplant ineligible, you perfectly said, sir, the NPM1 is the driver. So IDH1 is, we don't know, is it, driving the clone, and it is not. It is an incidental finding. So data and robust data is with azaven. But if you see the phase 1A, 1B data with azaven and a menin inhibitor, that is even better than azaven for NPM1 subset. So if there are no financial embargo on a trial, I would do azaven menin inhibitor for all those patients. But for what we end up doing in our patients with no access, to trials, I would end up doing azaven for these patients. I would not add an IDH1 inhibitor upfront for NPM1 and IDH1. This is my take, sir.
The question is azaven plus many of the 2 inhibitor which you want to target, you will go with the NPM1 mutation rather than the IDH1 mutation.
Absolutely.
I thoroughly agree. If you want to add a third molecule to that, yes, definitely NPM1 inhibitor, menin inhibitor, because studies are very clearly 7+3 have shown and data is very well available. I will add on to that. Definitely.
Okay.
Of the 2 molecules, I will go with
just
that.
one more question there. So I've now 3-4 cycles. She's done 3 now, and she's now DDPCR negative. Would you consolidate with the IDAC, or would you just continue azaven indefinitely? What is the
Is
next
it a
step?
molecular MRD negative molecule? Both
Yes,
the flow as well as
DDPCR,
MRD?
MRDs. Yes, MRD and both are negative.
MRD is a
In
negative
marrow.
because what is the age of the person? Are you consolidating
She's
with the
72
transplant?
now. No, 72.
72 is biologically young.
But
That's
she
not
is
a
not.
problem. Depends upon the
She will
comorbidity.
not tolerate a transplant. That is difficult.
Okay,
Yeah.
in that case, probably I'll continue with the therapy of both the molecules because both 2 mutations are there. Elderly patient, I will try to give it at least for 1 year. Then I will think about venetoclax reduction or whatever other things may be stopping, and then AZA. But I will never go for the AZA tablet. I will not go for the AZA tablet.
Right, sir. Right. Thank you, sir. Thank you.
Okay.
Thank you, Dr.
Thank you.
Yeah. So now I think we have to hand over back to Dr. Khushi and Dr. Kamble. Thank you very much profusely for bringing out such beautiful abstracts, both from the point of view of research, futuristic, and practice, not changing, but practice eye-openers for the future. And, thanks to this discussion, we are prepared for the future. So, Dr. Khushi, back to you.
Yeah, thank you very much, sir. And thank you all our esteemed panelists for such an engaging and insightful discussions. I'm sure that practical perspective shared today will extremely valuable for our participating clinicians. So for now, closing remarks and vote of thanks, I would like to invite Dr. Sanjay Kamble, sir, to proceed further. Sir, over to you.
Dr. Kamble, can I just make
Yeah.
one more statement before you give your vote of thanks?
Sure.
Just this audience, I want to tell this audience and the panelists that soon we'll come up with the EHA abstract, but of benign diseases or the benign conditions. So today was predominantly concentrated on malignancies. The next one will be on benign. So Dr. Kamble,
Sure.
over to you.
Sure.
Thanks.
Thank you, sir. Indeed, a very thought-provoking discussion that happened, and it was really nice. In fact, the Dr. Abhay Vabe sir has worked upon this agenda very meticulously, and he has scrutinized all the abstract from all the whole ocean that was available at EHA, and he has very concisely formulated this particular discussion, and he's now also shared his views about what future discussion we would be bringing up. That's really nice of him. And of course, all the speakers have really made their best of the attempt to present the data and share their views, what practically this data means when it comes to actually seeing the patient. So thank you all for those wonderful talks and nice deliberations that we had today. I would personally like to thank Dr. Abhay Vabe sir, Dr. Ramaswamy, Dr. Arjun Philip, Dr. Arun, Dr. Chetan, Dr. Sanket, Dr. Sudarshan Pandit, and Dr. Uh, uh, Ashish Dikshit, and Dr. Ankit Jetani, and Dr. Abhishek. So, and also all those others who were there as a panelist. And of course all the speakers and other people who have joined us from all the parts of the country, that really motivates us because and Dr. Kushi has shared the figure to be about more than 200 or 212 odd figures, so it was really motivating for all of us to see this large delegates who are finding our sessions very much interesting. That really keeps us motivated. Thanks all. And of course, thanks Mice Ideas to formulate such a digital platform and also getting us under on this common scientific platform. So, and of course, not the least, my team at Samarth Lab Sciences, Mr. Om was there, and Mr. Pawan Tiwari, who has been backing up the whole show for the last many days, and of course, my field colleagues. So, thanks all. And let us meet for the next discussion as we have the next coming updates that will be circulated shortly. Thanks all, and good night. Have a great day ahead. Thanks. Bye bye.
Thank you.
Thank you, everyone. Bye. Good night.
Bye.